Thanks so much for having me today. It's been a good morning. I'm excited to talk about something I'm really interested in, opiate use disorder and medications to help that, particularly in the emergency department. So as with the other talks, please stop, ask questions, interrupt. If I'm not explaining something accurately, call me out. We'll try and do that. In particular, in this area, I find it helpful to share experiences of other places you've worked at, places you've been, because there's a lot of emergency departments that have been doing a lot of work in treating patients with opiate use disorder, in particular over the last 5 years or so. And actually the VA has, as they do in many areas, a ton of resources in this, and so we have some good partners here. So a couple of objectives off the top. We'll talk a little bit about the scope of opiate use disorder, why we should care about it, talk about overdose education and naloxone distribution, which has its own kind of acronym in literature, and we're talking about this, and this is really focused on our role collectively of how we communicate this with patients and their loved ones in the community about preventing overdose and about making sure folks have access to naloxone. And then the last part of the talk will be about medication-assisted treatment, so medications for opioid use disorder. In particular, we'll talk about buprenorphine specifically. There are other medications that exist, like naltrexone, like methadone, that you've been familiar with, but the arguably most effective and certainly easiest from the emergency department is buprenorphine, and something that we can do, so we'll talk about that a little bit. And so to start off as boring as possible, this is the definition of opiate use disorder. It can be mild, moderate, severe, and these are some of the factors, pretty much the first half of the factors. So if you meet 2 of these, and there's another slide, that's mild. And if you're at 6 or more, that's severe. So you think about the folks we interact with. If you use a lot, there's some pressure, you spend a lot of time trying to obtain opioids, you have a desire or craving. And then there's a big category, right, of things just with other, and these are the DSM-5 criteria, I should say, with other diagnosable conditions, if it affects, parts of your life. And if you exhibit tolerance, exhibit withdrawal. So if you have a diagnosis of opiate use disorder, really only have to meet 2 of these. A lot of folks that we may see in the emergency department primarily for opioid-related concerns will have moderate or severe just by virtue of often ending up in the emergency department. And so a little bit of numbers. This is the most recent national CDC data from 2020, just to put some kind of scope on the issue, which is that over 10 million folks misused prescription opioids in the last year. And in 2020, there's a diagnosis of about 1.5 million people with opioid use disorder. And so we think about pills, we think about heroin, think about other synthetic opioids, fentanyl, et cetera. So a large majority of people or a large amount are trying heroin for the first time or have used it in the past year. And so just a little bit of the scope as well. This is the data from 2019. The vast majority of drug overdoses were opioid related. Wisconsin in particular has a really good website on vital statistics for county by county opioid use disorder as well. And so it's just a brief amount of the scope. This impacts a lot of people. We see that on a day-to-day basis. In particular, there's been a lot of research in the population you all take care of some specific risk factors, features, and ways to help prevent veterans in association with opioid overdose. And so the 3 takeaway points from this article, which I think are really good. One shows the significance that over kind of the decade of the 2010s, along with the rest of the population, opioid overdose has increased significantly. There are some unique factors in the veterans population, and that it takes a lot of different parts to address addiction and drug use in patients, but focusing on non-judgmental wraparound care and other solutions are really important beyond what, of course, we do in the emergency department. So then COVID did not help this at all, right? So the opioid pandemic was a huge issue before. We saw a lot of data related to the COVID pandemic of like 30% higher overdoses or ED visits for overdose in 2020. And like year over year, 2019 to 2020 was over a 30% increase as well too, with some pretty significant geographic distribution as well. And this is just another example from Chicago of they increased basically deaths by overdose year over year. And another way showing that fact. So I won't belabor the point of like this is obviously a huge issue, and the most important thing is what can we do about it. And so the first is to sort of like be aware of patients who may have opiate use disorder, whether or not they're coming in for an overdose or opioid related concerns, and then starting with like how do we assess them. So y'all may be familiar with the clinical opioid withdrawal score. Probably all use this in some capacity, which is the analogous to CWA for opioid withdrawal. And so some of these are the major components for like the toxidrome of opioid withdrawal. Sweating, vomiting, diarrhea, tachycardia, like agitation, diaphoresis, those sorts of things. And this scale is 0 up to 26 maybe. And a lot of things we do to target interventions are similar to CWA, are based on patient's objective score on this. And so over the past 5 years or so, there's been a lot of efforts around various emergency departments to what do we do when someone comes in with opioid withdrawal, right? Like in contrast to alcohol use, it's not deadly. It makes people feel terrible, but like ultimately, it's often something that was some symptomatic relief, fluid, Zofran labs, and follow up. But with the and if you were lucky, connected to care, maybe you were enrolled in a methadone clinic, maybe you got started on some long-acting opioid treatment. Again, lots of factors and things that sort of have to line up to be able to get patients care for opioid use disorder. And so this is one of the main papers out of Yale, and Yale has kind of been leading the way as far as treating patients with opioid use disorder in the ED, and this has been now copied and implemented across the majority of the country. And so this was a big argument made in 2018 that the ED is like the perfect place to treat patients with opioid use disorder. We already recognized it. We can treat symptomatically. We have a captive audience. We can start medications appropriately, and then linking to follow-up care so that they're not lost. It's one of the most important things. And so the first medication, or the main medication then we'll talk about, is buprenorphine. And so the trade name, just because I was confused for quite a while on this, is often referred to as Suboxone, which is buprenorphine and naloxone. And so this is probably something y'all are familiar with. Any idea why why is naloxone in this? This is a sublingual. The most common is like a sublingual version, but do you know why they put naloxone in it?
To prevent the euphoria.
Yeah, exactly.
What did you say, Jen?
To prevent the euphoria from the narcotic. It just fills your opioid receptors, but then blocks the other effects.
Yeah, nailed it. So we'll get into it a little more. The naloxone is in there specifically so that if it's in like the sublingual version or pill version, it's totally inert. And so naloxone, right, is like a complete opioid antagonist, just takes all the opioids off, will put you in withdrawal right away. And so if you take Suboxone in this form or in the pill, naloxone does not do anything, but it's activated if it's either crushed up or injected, and then it becomes something that prevents the overdose. So basically, the naloxone is in there to prevent any abuse of this medication. Jen talked about, so like just a brief little bit of pharmacology, not too much, so you stay awake. And so buprenorphine is a partial opioid agonist. So on the right side of the screen would be like your oxycodone or heroin, full agonist opioid. And then in the middle, that's the receptor. So right now, the opioid receptor is empty. In this case, they have like the red angry arrows because if you use opiates for a long time, your receptors want to be filled. So take an oxycodone, use heroin, your withdrawal pain goes away or your pain goes away, and you get that euphoric opioid effect. It fits, like this matches the receptors very accurately, and for oxycodone, short-acting opioids like heroin, this is something that will last then like 4 hours to 12 hours and really dissipate up to 24 hours. So then if you take buprenorphine, and buprenorphine's the now on the receptor, the kind of yellowish thing. So buprenorphine outcompetes, has higher affinity to the opioid receptors. So even if you have whatever is on there, full opioid agonist, buprenorphine comes in, kicks it off, activates the receptors so there's something there, and reduces those symptoms of withdrawal. So it reduces your vomiting, diarrhea, agitation, tachycardia, those sorts of things. But because it's just a partial agonist, it doesn't fit as perfectly as the green heroin, so you don't get the full euphoric effect, basically. And then buprenorphine, depending on the dose, can last a long time. And so because it has a higher affinity, it's more likely to stay bound to the opioid receptors. Even as the buprenorphine dissipates or it's been a while since your dose, it still has like, it's a pretty gradual taper off before your opioid withdrawal symptoms really come in. I'll pause there for a second, just so I can awkwardly take a drink in the middle of this. Questions or?
So even if they were taking the buprenorphine and then let's say they used heroin after that, the heroin's not going to bind to those receptors? Or?
Yeah, that's a good question. Overall, no. If you have a lot of buprenorphine, then you will, and you use a usual amount of heroin or take 5 milligrams of oxycodone, the buprenorphine effectively will stay on. However, it's still, and this gets into a lot of interesting things, like someone who's on buprenorphine chronically and then comes in, broke their leg, you can treat them with opioids. They just need a higher dose. So like eventually full dose opioids at higher doses will outcompete some of the buprenorphine. But in general, the mechanism in treating like addiction is that if you have buprenorphine on board, it's going to reduce the symptoms, the cravings, those sorts of things.
How long do people typically stay on buprenorphine or go to like Suboxone clinics?
It can be like really long term. It's often something that will be dosed twice a day, but they can do it from home, but you can be on this for a long time. Sometimes with outpatient setting, they can wean off depending how their symptoms are controlled, but yeah, they can be on for a long
So
time.
this is something you can withdraw from as well?
So not really,
Okay.
mainly because it's a partial agonist, so it doesn't have like the high euphoria symptoms. So that's one of the other benefits, is you don't really withdraw from this. It does bring up one of the sort of interesting situations too that we can talk about now, is if to start buprenorphine, someone already has to be in some degree of opiate withdrawal. And so that's because if you come in like completely, heroin overdose, where all your opioid receptors are completely blocked, you give buprenorphine and it kicks all the opioid off. And so you give what's something called precipitated withdrawal, which is sort of equivalent to giving someone a bunch of naloxone as well, like completely getting rid of everything off.
Sudden onset of withdrawal.
Yeah, sudden onset withdrawal. And so that's why the COWS, or your opioid withdrawal score, is so important, because you need to be having some symptoms of withdrawal in order to effectively start treating it, because then your receptors are already empty, wanting to have like some sort of opioid engagement on there so you don't feel like crap, and then the buprenorphine will be more effective. So I think it's just an interesting sort of pharmacologic situation.
This was either like with anticipation of like a follow-up or anticipation of an admission, or how do we keep them like on track once we?
Yeah, that's a good question. So there are really standardized protocols that most places can use, and so a lot of, if you have uncomplicated opioid withdrawal, so no other reason that someone would need to be admitted, or that they came to the ED because they're withdrawing on heroin, they don't have access, and they're open to starting treatment, you basically can do your COWS score and then give 1 dose of Suboxone, observe them for most of the protocols, say for an hour, which is a little bit arbitrary, but observe them to see if they're feeling better. And then you can give a second dose of the same amount, like a dose equivalent, and discharge them. Here, we're lucky to be able to have them follow up. There's a Suboxone clinic that's every Tuesday. There's some community resources in Dane County as well. And so this is something mainly would start on patients who would be getting discharged, just looking at this in isolation and the ideal plan is like discharge with the intent to follow up in a certain location, whether or not we're starting it here or in like a community emergency department as well. And so this one of the things we often talk about when talking to folks about opioid use disorder, talking about overdose education, naloxone are some of the myths and facts, and this was from one of the big papers in emergency medicine on this, about that the ED is really the option for combating the opioid crisis because we're always here and always available. And so some concerns are that starting buprenorphine may lead to more diversion or like more use of illicit drugs, buprenorphine getting into the wrong hands because it's associated with people who use drugs. As we talked about, because of the pharmacology, like you can't really abuse buprenorphine. If you try and inject it, then the naloxone is inactive and you don't get a high from it. So really there's not significant diversion. Compared to what like we all do on a daily basis of giving propofol and etomidate and heparin and lytics, like this is an extremely safe medication, and it's very protocol driven and has been proven in a number of settings. And so we often start at relatively lower doses. As long as you're seeing some improvement in the symptoms, they can continue on buprenorphine. A lot of the concerns early on were that this will like cause everyone to come to the ED and start buprenorphine. The reality is, like, if people are ready, not everyone's ready to stop using drugs, and there have been some changes such that now everyone with a DEA license can prescribe buprenorphine, which did not used to be the case before this past March, and so it's much less of a concern that this impacts ED volumes at all. And then that final point, like, not everyone wants treatment, but it's often worth asking or having the tools to like engage with patients about this. And so we can prescribe this here. I'm going to show just one example of a very common workflow, not to get in too deep, but at the top is uncomplicated opioid withdrawal. So nothing else going on, just want to help treat my symptoms of oxycodone withdrawal. I'm tired of using heroin, like I'm ready to get some help, those sorts of things. And then for some dose reference range, 8 milligrams is a pretty common starting dose. And so do your COWS score. Typically, if they're having obvious symptoms of opioid withdrawal, again, the numbers don't really matter. You click through. Usually that puts you at a COWS score of greater than 8. So you're tachycardic, you have some symptoms, you're agitated, you're throwing up, is at least greater than 8. It's very safe to give buprenorphine if your COWS score is like above 6. So unless you're still very acutely or still acutely intoxicated, is probably the wrong word, opioids, it's a very safe medication to give. So we talked a little about you can do 8 milligrams, watch them, make sure your symptoms are improving, 8 more milligrams, and then can discharge on 16 milligrams per day. So like 8 milligrams twice a day. Sometimes people will titrate this differently in the outpatient setting. That's not as important for us. And then the other thing to right at the bottom is co-prescribing naloxone or making sure that everyone can get Narcan. So we're trying, I would love to be able to hand out naloxone or Narcan for patients that come in with opioid overdose. There's some pharmacy barriers, but there are other VA facilities that do that, so something we're working on. And then we're fortunate in the state, there's a state direct Narcan program, so you may know you can go to any pharmacy and get a prescription for naloxone. So that's also something to encourage, either prescribe it here or just as you're talking with friends, loved ones, like community members, you can have naloxone for overdose education. This is like a small part of our provider workflow for buprenorphine. All this to say that there's a specific, like in the mental health area, we can write like Suboxone consult, and Dr. Dana Marlowe is one of the addiction psychiatrists who does Suboxone clinic right now every Tuesday. And so the ideal state is we prescribe enough buprenorphine until the next time is Tuesday. There's not really any danger or harm of prescribing it longer, but especially in a closed system, but just a mechanism to make sure that there's like close follow-up. And then the other thing that we lifted from the VA national websites is there's a ton of resources on this. Like it's diving in, it's like overwhelming to some degree. So on the bottom left, I know it's a little bit small, but the National VA, there's a VA ED like quick start guide for buprenorphine for prescribers, for like the facility, for tons of patient education materials, and we have very good partners with the mental health team on this who are on board. The prescribers are always up for answering questions as well too. And so getting back to a couple of key points, talking about the scope of opioid overdose, defining opioid use disorder, and then also most importantly, what can we do about it? So like all these things overall are important because they can, improve patient survival, decrease rates of overdose, and improve treatment retention. I'll pause there. The last couple of slides are just examples of some patient education materials that are lifted directly from the VA website that hope to get, and so are really simple ways, because I'm not always good at this, of like explaining to people at the bedside how to get Narcan, how to use Narcan, and how to recognize signs of overdose, because it's a super important public health intervention. So they do have like little card versions of these, or things that you can hand out to patients as well too. So this is responding to an overdose, like very simple. Sorry. Don't close CPRS. All right, that's still up. I didn't realize the screen looked totally different. So easy ways to like a pretty low health literacy level of how to use Narcan. We get a little more information, and then these are some of the resources that you can have available, hand out to patients. Things that have been. This was put out fairly recently by the VA, so I'm hoping to get some like physical copies of this, especially. It's not showing up there. Sorry.
I think I have to bring the mouse button back to the area and click on it.
Sorry. So this is something fairly new they put out nationally that I think is a really nice, easy thing to give to patients that has some important resources as well. So, I apologize, I didn't realize that was. This is the other slide I think I went away from, just having to talk to people about giving naloxone. That was all I had. Questions, comments, like other discussion about your experiences?
What are the barriers to ordering it in the ED? You know, there's some drugs where you have to jump all through all these hoops. Is this one of them?
It's a good question. Not anymore, fortunately. There used to be something called an X waiver, which was an extra, it was like one of the very few medications that you needed extra training for on top of a DEA license. And that has completely gone away. So it can be, we have lots of formulations of Suboxone stocked in the pharmacy, most commonly being that 8 milligram buprenorphine with 2 milligrams of naloxone. So it's much easier than it used to be when we started on this. So it's really nice.
So it's not like as difficult as like ordering like simvastatin or something like that, or not a simvastatin, but anti-lipid medication
Yeah.
type deal thing, where they have to go through this whole menu. And so a lot of docs, for boarding overnight,
Yeah.
we have a difficult time getting all of their morning medications because the docs
All the
just
menus, yeah.
they just give up and
Yes.
say they can get it inpatient.
Yes, absolutely. No, so all those barriers have gone away, like from a federal level, fortunately, and then also then now from CPRS as of like March. I think it was March.
How do we document the cows assessment?